Thank you once again for this invitation. So I've been doing bariatric surgery since now around 25 years, and as you see my case mix slide, we began studying the one anastomosis bypass in 2006. We published recently the functional results after 5 years in SWORD, all the complications we had out of the first 1,000 in obesity surgery. And we tried to study this operation as academically as possible with clinical data, long-term results compared to the literature. And we did also experimental studies in rats. So here are the results from October 2006 to December 2018. We had 1,630 patients with the following demographics. 18% of them had a failure of a restrictive operation. And at 10 years, the excess weight loss is 76%, with a BMI falling to 31. My topic is on the complications. So we had 3 deaths. And 2 of them are related to the surgery because of patients who were more than 60 years old. 1 pulmonary embolism at day 45, the BMI was 62, and 1 myocardial infarction at day 35 with a 63 years old man. So above 60, we always worry. There were 99 complications, so 6.1%. Half of them could be medically treated, and half required reoperation. Among the medically treated complications, the principal concern is marginal ulcer. Most of them could be medically treated for, looks like this one, a huge necrotic ulcer that occurred 1 year after the surgery, and the woman could no longer eat, but PPI treatment was efficient in that case. What about the reoperations? So 59 cases, 17 because of complications, and 42 because of revision for intractable bile reflux or weight regain, and 3 for malnutrition. I would just say one word about the leakage. Leakage is not such a problem. We had only three leakages. But it is potential bile peritonitis. So, you can, of course, suture the leakage, but I think if you reoperate early, the good advice is to convert into a Roux-en-Y to avoid the bile peritonitis, which is, as we all know, the most severe complication. But it's not such a problem. Another early complications was marginal ulcer perforation. We had 4 cases in heavy smokers. So this is always a concern to do a mini bypass on a heavy smoker. We tell the truth to the patient. Among all these patients, we had only 1 internal hernia through the Peterson space. So out of 1,600 patients. And I would just focus on the revisions so we had 23 intractable bile reflux that have to be reoperated, 16 weight regain, and 3 malnutrition. In the literature, the early complication rate is between 3 to 7. Perioperative mortality is rare. The first randomized trial published by OAGB showed an important difference of complications because he had 2 leaks out of 40 Roux-en-Y, which was considered as a high rate. Leak rate is between 0.7 to 2%, and half of them required reoperation. And I think conversion into Roux-en-Y is a good advice because of the bile peritonitis. Bleeding can occur. We spoke of that this morning because it's a long staple line. So sometimes we can use a reinforcement if necessary. Personally, I use the reinforcement if the patient has blood hypertension in order to avoid this bleeding. Small bowel obstruction is rare because there is only one anastomosis and no mesenteric defect. Mario Musella in Italy showed recently that the learning curve significantly decreased the intraoperative complication rate. You see, out of the first 50 cases, 1.2, and after 200 cases, 0.1% of complications. What is the most concern is the late complications, marginal ulcer, nutritional issues, and bile reflux. Marginal ulcers, the rate is quite different. Kamel Mahawa said out of 86 surgeons, the rate was 2.24. In our experience, we have exactly 44 out of 16, which is exactly the same rate, and 4 of them have to be reoperated. Bowel obstruction is very rare because there is no mesenteric defect. And I will focus on, nutritional issues and bile reflux. So we had to reoperate this operation for 3 reasons. We had to do conversion into Roux-en-Y, 23 patients. We had to do resection, sleeve resection, and we had to do conversion into normal anatomy in 3 cases. Intractable bile reflux seems not, it is a potential danger, but it seems not to be such a concern. In our experience, 23 out of 1,630 means 1.4%. It's a very special cohort of patients who began suffering 2 or 3 years after the surgery. They suffer day and night, and we give them PPI, and it doesn't work. It's 2 years after. They have lost all their excess weight, being BMI is 25, and we need to reoperate them and convert into a Roux-en-Y. The same rate has been shown by Musella in Italy, 8 out of around 1,000. Our experience, we did a mistake in that case because we said, well, there is one anastomosis. If we have to convert into a Roux-en-Y, we will do the other anastomosis 70 centimeters downwards. And in one case, we had malnutrition, protein deficiency, because the total limb length was only 2 meters downwards from the enteroenterostomy. So what I would say about that, if you want to add the anastomosis, the enteroenterostomy, you must absolutely measure downwards and be sure that you have 3 meters, more than 3 meters downwards. If you don't have that, you have to resect completely the anastomosis and do a regular Roux-en-Y gastric bypass. We did resection of the gastric pouch, and we recently published it in Obesity Surgery in 16 cases, exactly as it's been shown by Bruno with the Roux-en-Y. It's a huge dilatation of the gastric tube, like this, and that we recut along a calibration tube quite easily, and it worked quite well because the results were, as you can see, so it's a small experience, and the BMI fell until 30, as we can, with 1 complications with a splenic thrombosis and with infraction, which was quite okay after that. The question is about nutritional problem. Means hypoabsorption, protein deficiency can happen, especially if the BP limb is over 2 meters. There has been 1 publication of a case of death, but surprisingly, the BP limb was only 2 meters in that case. In our experience, we have 3 cases of patients that had malnutrition like this with hypoalbuminemia, and at 5 years their BMI was 19 with excess BMI loss of DSS. And those patients required, of course, parenteral nutrition and then reversal to normal anatomy. And Well, I've done that now seven times because we received other patients. It's a very easy operation. You just have to cut the anastomosis, do the gastrogastric anastomosis, and then either you cut it or you do another enterostomy. And when the patient has a BMI of 19, it's really easy. But we have a very small experience of that. But really, the question is about the limb length. Limb length should be 6 meters 92. I know Kamel will speak of that, so I will be very, very quick about that because the limb length can vary from 3 to 10 meters. And of course, if you bypass 2 meters out of 5 meters, it has different effects of it's out of 10 meters. We have done experimental studies in rats, and one of the big data we have is that the fecal protein loss is significantly higher after mini bypass than after Roux-en-Y. So there is a problem that can happen. But in the different papers, long-term papers, the malnutrition is quite limited. Either Routledge, no, they have shown less than 1% of malnutrition with a fixed limb length of less than 2 meters. A recent randomized trial has been published from France in the Lancet, comparing the Roux-en-Y to the one anastomosis and showing significantly more nutritional problems, 9 out of 0 with the Roux-en-Y. And in this trial, in which I was participating, we had to do a 2-meter long mini bypass. So this confirms also what we were trying to know is that 2 meters could be too much. And there is also this paper showing that nutritional deficiency are significantly higher for him. There are 3 different groups, BP-lim of 150, BP-lim of 180, and BP-lim of 250. And when you have a BP-lim of 250, you have significantly more nutritional deficiencies. Since now 5 years, we tried to do a BP-lim of 1 meter 50. And we saw that there is no significant difference in the BMI loss if we bypass 1 meter 50 or if we bypass the 2 meters in the past. That was the easiest way to have an answer to this question. But of course, the best is to measure the total limb length. It's been confirmed recently by Kamal that you must be extremely cautious if you use a BP-lim of more than 1 meter 50, because you can have malnutrition. So in conclusions, in our experience, it seems after now 13 years of experience that the one anastomosis is efficient with time, with excess weight loss of 76% at 10 years. The rate is 3.6% of reoperation. In case of leaks, which is very rare, the best is to convert into a Roux-en-Y to avoid bile peritonitis. There can be marginal ulcer perforation, especially in heavy smokers. The estimated revision rate after 12 years is 2.5%. Most common cause is intractable reflux, and conversion into Roux-en-Y must take care of the total limb length. Be sure that you have more than 3 meters downwards. Inadequate weight loss or weight regain is around 1%, and it seems that sleeve resection works if there is a pouch dilatation, and malnutrition is very rare, and conversion into normal anatomy is quite easy. The principal problem with the one anastomosis bypass is the limb length, and it seems that 1 meter 50 is enough when the preoperative BMI is under 50. I thank you for your attention.